persons in nursing homes. And while many of the things you could measure, like functional ability and psychological well-being, all those things could be measured, we were told to take a walk on the psychosocial side and to think about things that aren't measured through the minimum data set that's used in nursing homes. Does everybody's familiar with that? Anyone not? Everyone knows the MDS. We're moving from MDS2 to MDS3. So it's dark right now. MDS is dark. That's what they say, oh, it's dark, as though you don't collect it, you could look at it. So these were the dimensions of quality of life that we looked at in our study and figured out how to measure. Comfort, physical comfort, and sense of security. And though, you know, sense of security is also influenced by a feeling that you have a little control over your world. One older person said, I don't want to, I want to feel it's safe to close my eyes here. I want to predict what's happening. You know, I just want to, if the world seems crazy, people don't seem safe. I didn't feel safe while they were trying to get these slides up. And then this was a minor matter, but I was worried about it. And so those two, comfort and security, are kind of basic. If you know Maslow's hierarchy of human needs, you start out with the physiological needs and the basic security needs. Then we get into relationship issues. I used to have fun while I was doing this quality of life study, asking people what was more important, what was most important in these outcomes, and different people would have different nominations. I had one person who said relationships is the most important. You need to have relationships, even bad relationships. You need to feel connected to other people. Some people thought the safety was most important. Some people thought having something interesting to do and see, not be bored. Functional capacity means that within your cognitive and physical capability, you can be as independent as you want to be. That's a little more complicated than most of them. I think the asterisk should have been to a definition of it. And you can see that you can be made more functional by the physical environment you're in. You can be made more functional by the rules that govern the setting and so on. You're more likely to be able to comb your hair if you have a mirror at your own level. You're more able to, et cetera, et cetera. And of course, you have to be allowed to go into the bathroom by yourself. So functional capacity was not the same as functional performance. And then we had autonomy, you know, controlling your own life, dignity, privacy. That meant being able to achieve privacy sometimes, individuality, being known as a person. And there were other things we could have looked at, like the ones on the right, but we didn't. So we developed those measures, and I'm going to skip that one. We were very involved with trying to make a distinction between the outcomes. We measured those all as outcomes. You could ask the older person a series of questions. They could answer them. And we found that people could answer them with very substantial dementia. And you can't use the cognitive performance results on the MDS to know who can answer these questions reliably and answer them the same way the second time. It helps. There's a correlation. But some people have very bad cognitive performance scores and can answer the questions, and some of them have good ones and can't. Fewer of the second. So these are measured by the experience reported by the person, but what providers wanted to do is measure it by the program. We have these many activities programs, so we're meeting meaningful activity. We have a varied menu, so we're meeting food enjoyment. We wanted to measure it by the outcomes and then look at the processes to see what processes might help the outcomes. There's a real chicken and egg argument among the people who are worried about quality of long-term care and who think about indicators when they wake up in the morning. There's some people who say you never should have an outcome expected unless you can show people exactly what processes to achieve it. And so you should stick to the processes, the orthodoxy. Other people, and I'm in that camp, say define the outcomes, and then if people can get to them, let's look at how they get to them. So we tried to not look at the religious services, but look at what people said about about whether religious observances met their needs and a number of other items. All that is on my website, and there's a lot of information about the measurement of quality of life, and Natalie has given you in the jump drive you'll have the place to get to that very big study. But we were very excited. We found we could measure quality of life. We found it varied as a group measure across facilities. In some facilities there was a higher quality of life and some not. There was one slide that I thought I had put in, and I guess it's gone, but it was a slide about what characteristics affect quality of life in nursing homes. And obviously the person's health status and their functional status is going to affect their reported quality of life. Also the social situation, whether families are visiting, not visiting, etc. Also, and this is kind of a surprise, their personality. And we figured out how to measure personality from a self-report measure in old age. And yes, if you're a certain personality, you're going to report your life as crummy. And a certain personality, you're going to be more likely to report it as better, controlling for everything else. And there's that personality that is very justice-oriented, and if they don't have problems themselves, they see other people having them. There's a kind of a religiously oriented person who's very content and doesn't complain. So that makes a difference too. And then we asked ourselves the question, if all those things, people's health, their social circumstances that are out of families, out of providers' control, they think they're out of their control, the personality, if all those affect reported quality of life, what's left for health care? Is there anything left for health care? But actually there's quite a bit left. For one thing, these things, you can make it worse, you can make it better, you can make it worse. And actually, when you ask people whether they can affect what families do, at first they say no, they can't, and then they realize they can, through liberal visiting hours, through pleasant places, through outreach, you name it. There's a lot of things you can affect. And then it's the way people use themselves to fill gaps in relationships for those people who don't have them. There's things to do in each of those domains if you pay attention. And so there are things to do that are around the margins. So now we were going to be talking about challenges of services in whatever setting people are living with their chronic diseases. And clearly in the home and community side, it's harder to monitor. You need an information system. There's problems with the supply of qualified workers. And so there needs to be a system of oversight. We're interested in quality of a specific service, whether it's an injection or just anything you could imagine that wound care, and that you can look at how well that's performed, but then you're also interested in the experience of life, and you're interested in cumulative quality across all settings. Now, I'm rushing to think setting by setting. We'll think about home care. So we want nursing services construed broadly at home, and we also want personal care. Bathing, toileting, mobility assistance, help with eating, meal prep, escort outside the home. People are looking for that. And of course, medication assistance and medication management is a big, big issue. Then there's all the other services that can be brought in, or you can get people out to, like daycare, which I think is exaggerated in its importance. For those people who use it and it works well, it can be wonderful, but it isn't going to solve our system problems. Getting the right equipment, getting home renovation, family training, all that stuff. The question we have then is, a lot of things need technical competence, but to what extent do you need credentials to have capability? The people I had helping my father didn't have any licenses whatsoever, or my mother. The person in Florida did have a home health aide license, actually, and a certification, and she had a CNA certification as well. But most of the people didn't have it. And can they cut toenails? Can they look in a box and get a medicine? I would say yes, they can be taught to do that, and it can be made easier to do that. But often the regulations don't require that. One of the topics I've become most interested in over the years and have done work on in collaboration with a nurse researcher named Susan Reinhard, who's now heads the Public Policy Institute at AARP, is about the delegation of nurse tasks. And I wasn't going to go into this in a great deal of detail here, but I'm sitting in a room of nurses. I don't know what the Montana Nurse Practice Act says. I would be able to look it up. But most nurse practice acts, when you really look at them, allow very wide latitude for nurses to teach unlicensed assistive personnel, UAPs, to teach them nursing tasks. And in some states, they've done a lot of clarification about what that means, and they've clarified to nurses that if you teach properly and document, your license is not on the line, and so on. This is an incredibly important area for in-home services to be efficient and affordable. Because I'd rather have a nurse in the picture than not in the picture. And if they can be in the picture in order to show people how to do things, to delegate them, to see that they're doing it correctly, that's going to make it better. And if a nurse does have to come into a house 3 times a day to stick in an eye drop or to administer an oral med, well, that's ludicrous, especially if there's somebody living there who could do it. And I think nurses have been more comfortable over the years teaching family members than teaching a non-family member. So this is a big issue. And I think I could refer people who are interested to tons of documentation that Susan has done on this subject. There are 2 ways that we get around nurse practice acts. One is through exempting various forms of practice from the Nurse Practice Act, and the other is by building in delegation. I'd rather do the building in delegation than the exemption. And this is something that younger people with disabilities are very, very keen on. All the way to what can a school nurse do, and what can a teacher do? If the school nurse isn't around, can a teacher hand somebody his asthma medicine, get out a nebulizer if they need to? And so some of the breakthroughs have been built around child issues, but then they've been applied to older people. This is what older people care about in terms of the personal care and the homemaking. They want reliability. That means people come when you expect, they stay as they're expected, they're honest, they're trustworthy, brave, clean, reverent. And then that they do the task competently, and that's by their standards, how you would clean, how you would do whatever. They like the notion of a good personal relationship, somebody who cares about me and somebody I like. And that's a tricky thing because you don't want another family member, but it is, but that is important. And then there's the adequacy of the amount of care. So if people are buying it through an insurance system or through the Medicaid waiver program and there isn't enough time for it, that's another issue. So that's what the older people are looking for. These are goals that we have at the system level to make knowing that lots of people are using lots of different kinds of long-term support services. They use them consecutively, they use them simultaneously. They also have acute care needs. Somebody has to be alert to them, to know that if their conditions change, to avoid preventable hospitalizations, and to make all these care transitions smooth, and then the goal not to neglect all those things in the last bullet point, like eye care, dental care, foot care. These things are hard to do even when someone's living in a nursing home. They're even harder to do when someone's living in their own home. I don't think we'll need that slide. I'm trying to move along. Those are some of the quality categories that were developed by CMS for home and community-based services. They use the word participant. And and they develop subdomains like access to service. They have to get information, they have to get prompt eligibility, and the outcomes is that they can easily get service. For participant-centered, having it